So moving on with our instruction course of target emetropia, our first speaker, I would like to introduce to you Dr. Shreyas Ramamurthy. He is a cornea cataract and refractive specialist, and he runs the Eye Foundation group of hospitals. Today, Dr. Shreyas will be giving you an overview of biometry devices, and we know that biometry and an accurate biometry is the first and most important step in achieving emetropia, especially while using premium IOLs for spectacle independence. So we'll be looking at biometry from Dr. Shreyas.
Thank you. Thank you so much, Supriya, and thank Sri Ganesh sir also for his kind invitation to this course every year, and really look forward to always the discussions and the topics that happen every time. So today my duty is really to run through some of the overview of the biometry devices that we have available today. And whenever I deliver this talk, I am very fond of starting with ultrasound biometry. While it is probably, you hear it in many places, that optical combined with tomographers, combined with swept source OCT is the only way to go. I still believe ultrasound biometry has a role in our country where economic factors are a problem. And when you're using ultrasound biometry, probably what we should completely discard is doing a contact biometry and at least switch over to a immersion biometry. I will go through some of the aspects of where it actually differs, but with axial length being one of the most key variables, a difference between a well done immersion biometry and optical biometer in most eyes is below 0.1 millimeter of agreeability, where the IOL power really doesn't change much. What we really need to look into is the high quality A scan, ensure your spikes are in place. If the spikes are not prominent, then probably you're likely to have a greater probability of having an error, and ensuring you adjust the gain according to whether this is a denser cataract or whether there's silicone oil inside the eye. Increasing or lowering the gain accordingly is also important ways of ensuring that even in a difficult situation you get a very good axial length measurement. Probably the only area where we would not get a good repeatable measurement with ultrasound is in our eye with a posterior cephaloma or highly myopic eyes, where essentially we would be measuring the anatomical axis and not really the optical axis or the visual axis. And that is where the optical biometers would stand over an ultrasound biometry when it comes to an axial length measurement. Now moving on to keratometry itself, the manual autorefractometers, manual as well as the autorefractometers give you a good keratometry measurement, and you could use it in combination with an ultrasound biometry as well. With all the online calculators available today, even with that you can give excellent results in most of your premium IOLs. With the optical biometers, there's little to choose from. All of them have excellent agreement. Tomography measurements, especially in post-LASIK eyes, definitely has a role to play. The number of points measured seems to have less importance than the fact as to where they are measured. So because most of the regression formulae are based around the 3 millimeter zone of the cornea, as long as you get repeatable measurements on that central 3 millimeters, the device itself would matter less. One advantage with the telecentric keratometry is, while even if the patient is not so cooperative or the biometrist who's doing it is not focusing it perfectly, the distance between the spot remains the same. So therefore, even if the spot is blurred, you're measuring over the central same 3 millimeter zone of the cornea, and your repeatability in the measurements is much higher because of this particular aspect. What's really made a true change in the way we view biometry is our understanding of the posterior cornea and the posterior corneal astigmatism and the posterior corneal power itself. While regression formulae were useful and assumed a fixed ratio between the anterior and posterior cornea, we know that need not be the case, and especially in post-LASIK eyes where the ratio has completely been shifted, the total keratometry, which projects over the posterior torus points from the same anterior points, the 3 millimeter zone which you're measuring, the same points are projected onto the posterior cornea, and you get the posterior torus fit, which really gives you a very accurate measurement of the posterior cornea. Now, we already had posterior corneal measurements from Scheimpflug devices, but the problem with it is that the way the Scheimpflug device derives the posterior corneal measurements were not applicable to the formulae, the biometric formulae that we use. It was not that the measurement itself was wrong, but it was not applicable to the formula. So that is where the total keratometry, having its own measurement formula, has become more useful. And while we know that when we put in the measured values in the online calculators like the Barrett or the Baylor nomograms, we find that the mathematical measurements are better than the one derived from the Scheimpflug devices. But not as much with the case of the TK formulae, which are regression formulae calculated essentially for the total keratometry from the IOL-Master 700, where you have the Barrett TK Universal 2 and the Barrett TK Toric from this biometry device, and this formulae seems to give better results both in virgin eyes as well as make a truly better difference in post-refractive surgery eyes, wherein the Barrett TrueK TK gives you a better performance. And to corroborate this further, it was not just with the Barrett TrueK TK, even with the Haigis formula, when you use the Haigis TK, it gave better results than the Haigis L or the ASCRS average and the Shamas. So therefore, going for a measurement of the posterior cornea seems to be the way to go. Along with that, it gives you an angle alpha and angle kappa measurements as well, which is quite useful. The ACD measurements, which really are important for the ELP calculations, which are an integral part of most IOL formulae nowadays, are definitely better with the newer biometric devices, while the older ones were measuring from the epithelium and tended to overestimate a little bit more, was not very suitable in pseudophakic eyes. In pseudophakic ACD, there was a greater range of error. But with the IOL-Master 700, you are getting a B-scan biometry, which gives you a greater measurement of the anterior chamber depth, the lens thickness, and thereby ELP calculations become very good. Apart from that, having a good image of the foveal fixation also ensures that your repeatability of measurements can be ensured when you are able to image the foveal pit. When you don't image the foveal pit, you see that the variability of the measurements tends to be wider, and the IOL power selection itself can become quite significantly different. So this is one way of cross-checking whether it was your difference or the error in your biometry versus an error in the IOL power formulae. And like I already mentioned, both pre and post-operatively, this B-scan biometry or the swept source OCTs gives you a better prediction of ELP and ACD measurements. You can also look at the macula. And of course, most of the devices today are able to penetrate a little better, whether you're talking about the Argos or the various other devices which are now available, which combine biometry and topography. Now, this is the next step where the same device is now measuring your topography as well. However, the range of topography is quite variable, where some of them just give you an idea, a simple picture, whereas the more advanced ones like the Anterion give you a kind of a Scheimpflug device, an OCT-based topographic image, which is almost comparable to that of what we get in our Pentacam or Galilee. Reverse of that, you also have primarily tomographers which have axial length measurements like the Pentacam AXL or the Galilee G6, which are essentially Scheimpflug devices but giving you a good axial length measurement as well. So with all this, how do we choose from? The good news is that the results are very, very comparable, whether you're using a tomographer which is giving you axial length or versus a biometer which is giving you a very superficial, very simple anterior Pseudo-based topography. Anterion seems to have a combination of both, along with the MS39, seems to be one of the best devices for measuring various components of the eye. For paucity of time, I will not go into the details, but when you are looking at biometry today, we are looking at a whole lot more than just a keratometry and axial length. We are looking at white to white, we are looking at the lens vaults, especially with regard to phakic IOLs, the vault of the natural crystalline lens and the vault of the phakic IOL. All these measurements can be put in place. However, certain other devices, this is from the Aladdin, where you have a little more basic, simpler topography, but more than enough for your regular cataract patients to decide whether it's orthogonal astigmatism or not. This is from the IOLMaster 700, where you have this. You also get it from the Lenstar 900. Hagstraight has a reasonable, now the newer version has a nice topographer built in. So really, with the advanced imaging systems and the combination with IOL power formulae, which will be dealt with in the upcoming talks, emmetropia for all types of patients is a real possibility. Thank you so much.
Thank you so much, Dr. Shreyas. I think it's always for people who are starting their practice a point of confusion which biometer to actually invest in and go for. So I think that gives us a lot of insights. Thank you so much.